Good afternoon, everyone. I'm Madeline Milka, APEC's President and CEO, and welcome to the second panel of the APEC's Legislative Leadership Series, with weekly discussions through the month of August and 2 times a week in September. Today, we are talking with a panel of experts about health access and the AAPI community. I want to take some time to thank the sponsors of today's panel, Bristol Myers Squibb, Novo Nordisk, and Pharma for their support of this very important discussion. Before we get to the conversation, it is my honor to introduce Congressman Andy Kim, who will be joining us for opening remarks. Congressman Kim represents New Jersey's 3rd District, and he also serves as the freshman representative within the leadership team of the Congressional Asian Pacific American Caucus, or CAPAC. He is a champion for the AAPI community on Capitol Hill, and most recently is serving as a member on the Select Subcommittee on the Coronavirus Crisis. Please join me in welcoming Congressman Andy Kim.
Hi, everybody. Thank you so much for having me. I'm really honored to be able to just kick this off and get things started and be able to hand it over to the experts that know a lot more about this than I do. But there's obviously something I just wanted to pass along, which is just, through the work that I'm doing on the Select Committee on the Coronavirus Crisis, being the only AAPI on that committee, we have heard of all the different health disparities that are happening out there, especially when it comes to health access to minority communities, the AAPI community. We had a hearing about that, and it's something that just hits home, just the problems that we've had. And a lot of this was happening even well before the coronavirus crisis. So, but the crisis is really pushing our system to the max and really exposing and bringing out to light a lot of where those disparities are having an impact in terms of people's access to be able to get what they need. And this is something that we just need to make sure that we're focused in on. I promise you, as someone who's on that select committee, the only AAPI in there, I'm trying to use every opportunity I can to be able to make sure that we are raising up the importance of these issues, that our community is not being marginalized in these discussions, and that consideration is being given, whether that's with regards to the stimulus package and the support that we're trying to be able to provide on the health access side, on the small business side, as I'm on the small business committee as well. All those different aspects are critically important. But what we need to make sure we're doing right now is listening to our experts, listening to what they think are important for us to focus in on, and which is why it's important that we have this panel today. I truly believe that this is a situation where not only are we trying to help people through this on a day-to-day level, taking steps to be able to, for instance, even in my district, as I'm driving around today, I've talked to a number of people here who, when they went to get their coronavirus tests, had to wait 7, 8, 9, 10 days to be able to get their results back. Still problems that we're facing across the board. On contact tracing, the inability to have a wide range of languages, for instance, that are being spoken, especially languages and dialects of the AAPI community, that continues to be a problem that we're facing across the board. So we're trying to make sure that we're addressing these issues on a daily basis, but we also need to make sure that we're looking at this with a longer horizon, with a systemic mind about what it is that we need to do to make sure that when we come out of this crisis, that we can make sure that we're in a better place in terms of ensuring that we have that equality and the fairness across our system to make sure that we're taking those steps to shrink the types of gaps that we see out there, make sure that different communities and the AAPI community have what they need, and that we're moving in a better direction. I do believe that a lot of the decisions that we're making right now are feeding into that and will inevitably have a longer term impact. Now the question is that for better or worse? Is that something that we know is going to be moving forward in the direction that it should be? Which is why this panel will help us think through what are those challenges and what can we do to make sure that we are helping out across the board. I'll continue to do everything that I can to make sure we lift up our voices and have that heard in Congress, in the highest levels, and in states around our country as we're doing this response and trying to coordinate it across this country. And I'll be making sure I'll pay close attention to the ideas talked about today and elsewhere to be able to do that. But with that, I want to turn it back. But as I said, please, everybody, I hope you're staying safe and healthy. I hope you're getting through this. And I'm looking forward to be able to work with all of you to be able to make sure that our concerns and voices are being listened to. Thank you so much.
Thank you, Congressman Kim, for your remarks. We appreciate you taking the time to join us. Next, I'd like to introduce Carolyn Ha, who is joining us today representing Pharma, one of the sponsors of today's panel. Carolyn is a director in the Policy and Research Department at Pharma, where she provides clinical expertise to shape policy development and advocacy related to population health and chronic disease management, improvement of medication use, and clinical and quality management strategies. As a clinician, she is passionate about patient care and translating research into actionable policies that will ensure patients get the most out of their medications and creating a sustainable healthcare delivery system that incentivizes innovation. Please welcome Carolyn.
Thank you so much, Madeleine, for that introduction, and thank you all so much, especially to APA ICS, for having me on this panel and as part of the leadership series. Pharma is delighted to be a sponsor not only of this great event, but just the work of APA ICS overall. And so it truly is a pleasure to be with you all here today, at least virtually, and at a safe and socially acceptable distance. I hope that you all are staying healthy and well. You know, I think as Madeleine said in her intro, ensuring equitable health access is a passion of mine. It's really the reason why I went into healthcare and health policy to begin with, and I'm really proud to be with an organization that is representing the leading biopharmaceutical and researchers and scientists who are working nonstop during this unprecedented global pandemic to beat COVID-19. Our member companies have mobilized in a few short months, and I'm really encouraged by the rapid progress that we've made so far. And so I'm really excited to share with you how our industry is rallying not only to fight back against the coronavirus, but also against systemic racism and inequalities that have long plagued the healthcare system. So first, I'll start off with an update on the progress that we're making against COVID-19. America's biopharmaceutical companies are working around the clock collaboratively and across the globe in really 4 key areas to beat COVID-19. The first is in testing. Life science companies are working together to develop diagnostics to help better test for the virus. The second area is in repurposing existing medicines. So scientists right now are rapidly screening their vast global libraries of medicines to identify potential treatments and making those medicines available to patients right now through clinical trials or compassionate use. And these products include, antivirals that you may have been hearing about in the news, such as remdesivir, but it also includes immunologic agents and anticoagulants. Third, we are also developing new medicines. So these scientists are also developing newer therapies and treatments for those who are infected. This includes using exciting technology like plasma technology and also monoclonal antibodies for treatments. And lastly, we are working to develop a vaccine to hopefully prevent against future infections. And, the immune system is really tricky and how the body responds to this virus. We're learning more and more every day. And so not all of the potential vaccines and treatments that are being tested will work, which is why we need as many shots on goal and viable candidates as possible. We do believe that the biopharmaceutical industry is well positioned to succeed. We have a very robust biopharmaceutical ecosystem in the United States that is helping us to be able to respond as quickly as we have been so far. So first, we have deep and vast knowledge of, that has been gained through several decades of studying, similar viruses such as influenza, HIV, Hep C, SARS, and MERS. So taking that knowledge has dramatically improved our likelihood of success in developing an effective vaccine and identifying any treatments that could work for those who are infected. Second, our industry has invested billions of dollars in technology that has also dramatically shortened the time it takes to decode this vaccine, to decode the virus to be able to develop a potential vaccine. And our industry has also expanded our manufacturing capabilities and really ramped up the production capacity so that if and when we have successful candidates, we are ready and prepared to supply those vaccines and treatments to the public. The last point I'll make on this is that we are also, just as importantly, working hand in hand with governments and insurers to make sure that these potential treatments and vaccines are going to be made affordable and accessible to patients. So while we're confident that the industry can and will rise to this challenge, it's important to note that our companies are also doing this at substantial financial risk. We don't know what may or may not work, but we are pushing through because we believe that that is what is good for public health. We truly do believe that the science is what is going to bring us back to normal, and we will continue to do everything we can to beat this virus as quickly and as safely as possible. I'm going to switch gears a little bit and talk about kind of the lasting effects of COVID, as Representative Kim alluded to. I think it's safe to say that the COVID-19 pandemic has reshaped nearly every aspect of our society, including the healthcare system and the way care is delivered. And the effects of this pandemic really are not going to go away anytime soon, just because we found a vaccine and most of us are able to return to some sense of normalcy, whatever that may be. There's still underlying issues like patient affordability and quality of care and health access that are critical to the economic recovery of this country. As so well often, you see that health is really tied to wealth as well. And so we have really seen those fault lines drawn in the health disparities that have been magnified during this pandemic. And while pharma's member companies are really working tirelessly to find medicines and vaccines to combat COVID-19, we also recognize the need for evidence-based research and cross-sector partnership to tackle the other key questions to address health inequity in communities of color that have been highlighted and exacerbated by this public health emergency. We are committed to working to fix the healthcare system so that it works better for all Americans. And so in 2019, Pharma established the Health Equity Roundtable with the goal of improving health outcomes by addressing inequalities in care. As part of that Health Equity Roundtable in 2020 of this year, Pharma provided grant money to spur ideas for practical interventions to address the alarming health inequalities that have been created as a result and highlighted during this COVID-19 pandemic. And I have to say that we were so blown away by the submissions that we got in the first round that we are likely to continue a second round of grants. So please keep your eye out for when we might open up the submission windows. We, got some really great ideas on community-based interventions, those with community health centers, such as yourselves and the other panelists that are going to be speaking later on today, that we'd really like to open up potentially for another round of grant money to go out to the communities and meet the needs where they are. Lastly, we wanted to note that in the wake of really important conversations that have taken place over the summer, timely conversations about diversity, equity, and inclusion in all spaces of America, our companies are also pushing for the necessary and positive change and long-term systemic changes that are needed to better meet the needs of all patients as we seek to fulfill our duty as the developers of innovative medicine. We are seizing on this moment to address systemic racism head-on, to have those uncomfortable but really necessary conversations, to push through and move forward so that we can be better allies and advocates for all patients and communities of color. I just want you to know that this initiative within Pharma is not meant to be, just a flash in the pan. This is coming from all levels, the highest levels of leadership within Pharma. It's our board that is urging us and the industry to really come together and show our commitment and unity in the fight for equity and systemic change. And so last week, we launched a pretty powerful ad laying out our industry's principles and long-term commitment to addressing racial justice and equality. You'll see here that our statement is that systemic racism is as real as any disease, and our industry is not immune. And so we realize that. We also realize that there's a lot of work and trust that still needs to be gained and earned within these communities, such as respecting different cultural preferences for healthcare and just a lot of systemic issues that has led to kind of where we are today. But we're committed to that change, and so I really encourage you all to visit pharma.org/equity to learn more about our goals and to track our progress. And so again, it's just really been an honor and a pleasure to be able to join you all and be a part of this panel today. Really looking forward to the conversation over the next hour or so. And so I will hand things back to Madeleine. Thank you for the opportunity.
Thank you, Carolyn, and thank you again to Pharma for your generous support of this panel and for your commitment in support of communities of color. Now it's my pleasure to get this conversation started and to introduce the moderator for today's discussion, Irene Bueno. As the co-founder of NVG, an impact-driven government relations firm with decades of experience working in and with the highest levels of government, Irene has developed extensive high-level relationships across government, including in the executive branch and Congress. At NVG, Irene draws on her networks and knowledge of the executive and legislative branches to promote clients' policy objectives. Most recently, her clients saw their policy priorities reflected with the inclusion of language in the Affordable Care Act and the Higher Education Opportunity Act. And in every Congress, Irene ensures her clients secure critical funding for medical research and education programs. In addition to being a former AAPI board member, Irene is a leader in the National Asian American and Pacific Islander community. We are thrilled to welcome her to this discussion as our moderator. For our audience, if you are joining us on the webinar, please put your questions in the Q&A box. And if you are joining us on Facebook, please put them in the comment section. Thanks so much, Irene.
Great. Thank you so much, Madeline, for that very kind introduction. And I'm so thankful and honored to be welcomed back as a moderator for this health panel. As Carolyn said, I'm very passionate about health issues. I've worked on it from all different aspects, but this year is obviously very sobering as we discuss health issues. So we have a number of experts on the panel today, and we don't have a lot of time, so I really would like to turn it over to them to first introduce themselves and then give some remarks, and then we'll have an opportunity for some questions. So first, let me introduce Adam Carbolito, who is the Director of Policy and Advocacy at the Association of Asian Pacific Islander Community Health Organizations, also known as APCHO. I will now also introduce Ben Devanzo. He's a Senior Policy Analyst with the Asian Pacific Islander Health Forum. Dr. Ken Fujioka, who is the Director of Nutrition and Metabolic Research and Obesity at the Scripps Clinic. And finally, Priscilla Coe, who's the Associate Director for Bristol Myers Squibb Foundation. So I want to welcome all of the experts who are on the panel today and ask them just to give a brief opening remarks, and then we'll turn it into some questions. So Adam, let me kick it off with you first.
Thanks, Irene. Thanks, Madeline. And thank you, Congressman Kim, for your welcoming remarks. As Irene mentioned, I'm Adam Carbolito, the Director of Policy and Advocacy at the Association of Asian Pacific Community Health Organizations, or APCHO. We are a nonprofit association of community health providers that was formed in 1987 that works to advance policies that promote better health outcomes and access for medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders in the United States, the US territories, and the freely associated states. As I mentioned, we do represent, or we are an association of community health centers and other community health organizations. We have 34 member organizations throughout the country, including 28 federally qualified health centers that serve nearly 750,000 patients annually. And I'm very appreciative to be a part of this panel.
Thank you. Now I'd like to recognize Ben Devanzo for opening statements.
Thanks, Irene. My name is Ben Devanzo, and I'm Senior Policy Analyst at the Asian and Pacific Islander American Health Forum, which is the nation's oldest and health policy organization working to advance the health and well-being of Asian Americans, Native Hawaiians, and Pacific Islanders. We work to improve access and quality of care for Asian American, Pacific Islander, and Hawaiian communities, many of whom are predominantly immigrant, limited English proficient, or maybe new to the U.S. healthcare system. We have long-standing relationships with over 150 community-based organizations across 35 states. And we provide capacity building, technical assistance, and advocacy in particular as the clear, strong voice for the needs of those communities in Washington, D.C.
Thank you, Ben. Dr. Ken Fujioka, would you like to say a few words?
I'm not sure what to say. I'm not a politician. It's just,
Just introduce yourself, please.
just a physician, endocrinologist by training, and I do research in metabolism and how humans regulate weight.
Thank you. Priscilla, would you like to introduce yourself?
Hi, good afternoon, everybody, and thank you, Irene and Madeline, for this opportunity. So my name is Priscilla. I have the privilege of working at the BMI organization as an associate director. We are a 501c3 separate from our donor and parent company, the BMI Squad, and our mission is to promote health equity and improve health outcomes for populations disproportionately affected by serious diseases. We do that by strengthening healthcare workers' capacity, integrating medical care and support with community-based supportive services, and mobilizing communities that disease. So it's a pleasure and honor to be on this panel with everybody here today.
Thank you all. I'm going to just start off with a few questions. Ben, I'd like to turn to you first. Ben, could you provide us just with some bit of basic information about health in the AAPI community and talk about some of the basic access needs of the AAPI community when it comes to our health?
Sure. And can you all see my screen okay? Did it show up?
Yes, we can. Thank you.
So I do have some slides in to help me answer this question a little more visually. So we talk a lot about, particularly at the Healthcare Forum, the need for all people, regardless of their background or status, to have access to health insurance. And we really look in particular, considering the context we are in right now, at the Affordable Care Act and the really great progress we have seen over the past 10 or so years since it was passed, 7 years since it started to be implemented for the Asian American Pacific Islander communities. And in fact, for Asian Americans, we've seen the uninsured rate disparities between them and whites eliminated, and at least when you look at Asian Americans as an aggregate. They have seen their uninsured rate drop from nearly 14% to just over 6%, essentially being cut in half. And this represents over 1 million newly insured lives. And really in the context of the Supreme Court potentially this fall looking to review the constitutionality of the Affordable Care Act, as well as recent policy attempts to repeal it, we really value and look at that progress we've seen. Pacific Islanders have also seen a really significant drop in the uninsured, although we have not seen the elimination of the disparity between them and whites. And in fact, while their uninsured rate dropped from nearly 14% to 7.5% in 2016, over the following 2 years in 2017 and 2018, which is the most recent data we currently have, it actually increased up to 8.6%, the only race group that saw such an increase. And so that's something we're concerned about in our watching. Of course, you can see that other race groups also have quite high uninsured rates for African Americans and Blacks, for Hispanics, for American Indians and Alaska Natives. And that's why we know that because these high uninsured rates for all groups and these disparities are driven by systemic policy decisions that have led to these disparities, we really value the multiracial coalition we work in tackling. And particularly for us at the Health Forum, we work a lot on Medicaid, considering that 15% of Asian Americans and 32% of Native Hawaiian Pacific Islanders rely on Medicaid, which was expanded into the Affordable Care Act. And now in many states, but not all, is the primary program for coverage for people who are lower income, have disabilities, or are elderly. However, I mentioned that aggregated uninsured rate for Asian Americans. And in fact, we know that we cannot just look at aggregated data when it comes to the community. And doing so obscures the very, very deep differences that we see between people based on their ethnicity or subgroup, depending on how you look at it. So we really use this graphic a lot to demonstrate that, yes, many, many groups and all Asian American Native Pacific Islander subgroups for which we have data did see really big drops thanks to the Affordable Care Act. For many of them, we see persistently high uninsured rates. And we saw in some groups insured rates that dropped a lot more than others. And that tells us important information about what groups are being included in policy changes and what groups are not reaping the full benefits. But we really look to now for how Micronesians with a 13.1 uninsured rate, or Burmese with a 13.2 uninsured rate, Thai folks with a 10.3% uninsured rate. So very high uninsured rates that are not nearly, clearly not an eliminated disparity. And that shows that there's a lot of work left we have to do. However, the problem is that while we do have this uninsured data disaggregated, there's a lot of data that we do not have that is disaggregated, and that remains a consistent problem in policy work. In addition to uninsured rates, we know there are disparities among Asian Americans and Hawaiian Pacific Islanders in a variety of health conditions and outcomes. Even though we often hear the model minority stereotype applied to these populations in the health context, as it is in many other contexts, we know it is not true. We know that Korean men and Hawaiian women and Korean women have persistently high stomach cancer rates, that Laotians have high liver cancer rates, that cervical cancer incidence rates are higher among Cambodian women. We know that in particular, Asian Americans are very disproportionately represented in the hepatitis B cases in the US, and Native Hawaiian Pacific Islanders have great disparities when it comes to diabetes. And of course, the same thing I said around disaggregated data is true when it comes to these sort of disparities. 14% of Indian Americans have diabetes, a higher rate, nearly higher than most other race groups, and particularly whites. It is about double of whites have a 7% diabetes rate. And Samoans are more than 3 times more likely to be diagnosed with diabetes than the overall US population. So in addition to understanding that when we talk about disparities in healthcare and health conditions for Asian Americans, we also, again, as much as possible, need that disaggregated data. So I think I'll leave it there for the overview in terms of what we're seeing and allow us to move on, and we'll fill in additional details as we continue our discussion.
Thank you so much, Ben. I think that was really great to provide everyone with some basic information about the number of AAPIs who are uninsured. I want to turn to more of a specific issue, issue of obesity. It's an issue that affects many communities, including AAPIs, but there seems to be a lack of awareness among providers and AAPIs themselves about what obesity means. So Dr. Fujioka, as an expert on obesity, can you talk specifically about how the definition and thresholds for diagnosis are different for AAPI individuals? And what challenges does this present, and what can we do about it?
All right, I'll give it a try here.
Okay.
Convert my screen over, share. Hopefully this works. So can you see my? Great, okay. Need to understand first what is obesity, and I'm sorry, I'm not a politician. I'm sure I'll say politically incorrect things. I'm just going to give you the facts. In essence, it's when somebody's heavy enough that their lifespan is shortened. They're going to run into medical problems, whether it's diabetes, heart disease, sleep apnea, whatever. And in 2013, obesity was put into stone as a chronic disease. The reason why is this: whatever is the weight that any human being reaches, the highest weight that they reach, they attain, that becomes the new set point for the rest of their life. In other words, the body will shift hormones around to make sure they stay at that highest weight forever. That's why it's so hard to maintain a lower weight. So the hormones that drive you to eat, and believe me, we know them all now. In the last 10 years, these have all been figured out. And a lot of doctors do not know this because this is new information. But the hormones that drive you to eat, they actually go up even higher if you're below your highest weight. So let's say you're supposed to weigh 150, you got to 200, you lost 20 pounds, you got down to 180. Well, all of a sudden the hormones that drive you to eat are very high, driving you to eat more. Two, the hormones that tell you you're satiated, you ate a meal, stop eating, you're okay, they drop, they go down, and they won't come back up until you get back up to 200 pounds, even though it's still too heavy for that 150-pound frame. And then last off, there's this huge drop in metabolism so that you drop your metabolic rate 300, 400, 500 calories per day to try and get back to that highest weight. So that's what obesity means to us. So how does this affect the Polynesian and the Asian? My family is a mix of Polynesian and Japanese. So I look at both sides of this equation, and in essence, for Caucasians, these are the numbers that are used for everybody though. It doesn't matter whether you're African American, Hispanic, Asian, these are the numbers used throughout the US. Now they're different outside of the US. If you go to China or Japan, it's a little bit different. But a normal BMI for a Caucasian is 18.5, 19 up to 24.9. And this BMI is body mass index. It's just weight divided by height squared. In other words, an equation to, as you get taller, you should get a little bit heavier. And that's all this equation takes into, effect. Overweight is 25 to 29.9, and obese is 30 or higher. So for Polynesians, because as Polynesians get larger and their evolutionary tale is just fascinating, but they gain a lot of lean tissue, organs, muscle, bone. So they're actually really not obese until they get to a BMI of about 34. So that's okay. They may be misdiagnosed as obese when they're really not a big deal. But for the Asian, it's the other way around. Asians, we're considered obese when our BMI is 25 or higher. The reason why is that's when the medical problems start. The diabetes, the heart disease, all that starts much lower. And the reason why is as Asians, we don't gain our weight all over. We don't get more what we call peripheral fat. We get what's called central fat, or the apple shape. So you gain your weight here in the central region, and that weight is in your kidneys, in your liver, around your heart, around your intestines. That's bad fat, because it's constantly turning over very, very quickly, releasing free fatty acids, creating all kinds of problems. It's very inflammatory. The inflammatory factors go off the wall. So in essence, Asians are at risk at much lower rates. So let's take an example. BMI 30, Caucasian, men and women were meant to be the same weight for any given height. So we can use this for either a relatively taller woman or a short man, but anyway, 5'4", obesity would start at 170, okay? But if somebody has a BMI of 25 and they're Asian, now they're obese, and all of a sudden, that's 128. That's a huge difference in weight. And so it tells you how, again, the weight is not tolerated very well. Polynesians, on the other side, you go up to 192 before they're truly obese. Why is this an issue? Because if you get into an electronic medical record, where I spend half my day when I actually see patients, it's the first thing that comes up. In other words, it's a vital sign. It's like a blood pressure, it's like a pulse, it's like your temperature. And so it's put into the record, what is your BMI? And if it's too high, then we get a little red mark telling us we need to do something about it. So where this is all getting determined though, and again, if you go outside of the US, it's a little bit different, but if in the US, it's determined essentially by the FDA and the pharmaceutical companies, because if I want to use, say, a weight loss medication, or I want to use a certain hormone or something like that to help somebody with their weight, I can't do it until their BMI is probably 30. Whereas an Asian, they might have a BMI of 26, 27, they could use this help. They could basically put their diabetes in remission if they lost weight, but they would not be a candidate because, again, it's not approved in the US at those lower BMIs. So this is the tough one. And for me, it's been hard to watch. And so I'm always considered the voice of reason whenever we have these big meetings with a bunch of docs, and they get it, they understand it. But again, it's different in the Asian population and hurts them, in my opinion, the most. I don't know if you want me to go on and talk about coronavirus, because that actually is an obesity risk factor.
Go ahead. I think it just flows right into it. And then Adam, I'll recognize you next. Yeah.
All right. When you look at the top 5 reasons why patients who get severe COVID, so in other words, we're seeing a lot of COVID out there. Sure, a lot, millions of people are getting it. But one group is doing very, very badly. And believe it or not, that's the patients who are in the obese category. and particularly younger patients. So under the age of 60, if somebody is overweight, when they get COVID, they do much worse. They end up in the hospital sooner. They end up in the critical care unit. They end up on ventilators. This is scary stuff. And so again, fat cells release tons of inflammatory factors. And one of the mechanisms of why COVID is such a tough disease is because it just heightens all inflammatory processes in the body such that you can die of just the inflammation. In other words, that's why it hits so many different organs, the brain, the kidneys, the heart, everything. So again, if you're an Asian patient, they'll say, okay, yeah, you got a BMI of 27, 28, you know, you're not that overweight, you got it, we'll just watch it, don't worry about it, you'll probably just come through it fine. Maybe not. They might be, they're now obese, they're at higher risk for having problems. So again, it's just, to me, it's not an access issue, it's really a question of education, so that healthcare providers are okay. Now, fortunately, now I'm in California, and very quickly, the majority of physicians are actually Asian. So they get it, they know this. But again, if you go outside California, I bet things are different. I was shocked to find Dr. Kim's from, or the representative politician, Mr. Kim, is from the East Coast, which I didn't even know there were Asians over there. No, just kidding. But in essence, again, in areas where you don't typically have a very strong Asian community, this is not known.
Wow, that's really fascinating, Dr. Fujioka. And you might not be a politician, but you're an expert in your field. And I know I've been working in healthcare issues and did not have this information. So I really appreciate you sharing with us. Now, Adam, I'm going to turn to you about talking about health access. We know that there are a lot of factors that limit APIs from accessing healthcare. So can you talk a little bit about some of those challenges that our community faces and what organizations like yours are doing to mitigate those barriers?
Yeah, absolutely. And I think, you know, what Dr. Fujioka was saying really drives the point of what are some of the barriers that that our communities experience regarding access to care. And one, it really is a cultural and linguistic competency among healthcare providers and just in general on the ability of patients to communicate with their doctors, doctors to communicate with their patients, and them prescribing culturally competent interventions that really drive you know, how they're going to receive care and what procedures might be necessary for them. So really, like, cultural competency and language access is a critical challenge I think we see in many healthcare settings, and particularly COVID-19 has exacerbated our recognition of this, is that language barriers, the ability of translation services or translated materials to be available to patients is not readily available in many healthcare settings, but it's also where are our communities getting care? And I think that's one thing that AAPI, as a organization that represents community health centers, really tries to underscore, is that for our communities, trust is a big factor in how how and when and where they're going to receive care. They need to be able to trust that the doctors that they're going to see really understand their challenges, as Dr. Fujioka was saying, is that, you know, there are different there are different parameters, there are different considerations that you have to take when dealing with different populations and different individuals, that if they don't trust that you understand their culture, that you are going to be able to effectively communicate with them, that they may not come in for care, or they may delay care, which we're seeing in COVID-19 with patients not going into their doctors for a variety of factors. One being, I think, what Carolyn was saying, like a concern about them seeking care because of some of the racism and some of the other challenges that we've seen and that has been prevalent in our communities. But also, Ben was also alluding to this, is that there are data challenges that we have when trying to understand what these interventions that might be necessary. And he was saying, like, you know, in the aggregate, AAPI communities seem to be doing okay. some of the health disparities may be blended or masked because we don't have a good availability of data disaggregation in this country, where some communities may seem to be doing better, but while other communities are very much disproportionately affected by different diseases, by different by different diseases. But one thing that APCHO has been doing to try to overcome some of these challenges is really pushing for greater disaggregation, but also providing for those interventions for specific diseases that does disproportionately impact our communities. For example, like we've been successful in standing up a Pacific Islander diabetes prevention program that really does those targeted interventions for Pacific Islander communities, taking into account their cultural and linguistic, their culture and the linguistic challenges that they have. We've been trying to provide for better advocacy around hepatitis B in ensuring that Asian Americans do have access to hepatitis B interventions, and also ensuring that policymakers do understand that we need to find that we need to support programs that'll bring down hepatitis B within the country, and also promoting better accessibility to hepatitis B vaccines. We do have a vaccine for hepatitis B, but there is no cure for it. So if we can get it to communities earlier and ensure that they are vaccinated, that is something that'll really help to drive down the prevalence of hepatitis B with our communities. But I really want to go back to this, the concept of trust within our communities and having patients go to providers that they do trust, like community health centers. Our community health center model is that we provide care to any person who walks through our doors, regardless of their ability to pay. And it really is that model that'll help to drive down some of the challenges, and APCHO members in particular do provide for those culturally and linguistically appropriate interventions and care that's necessary, and providing those linkages both within our health centers, but also within the community to other organizations that might be able to help them.
Thank you so much, Adam. Now I want to turn to Priscilla. Priscilla, can you explain a bit more about your role at the BMS Foundation and give us a sense of the ways that entities like yours are investing in helping the AAPI community to address access to healthcare issues?
Sure, thanks, Irene. And actually, it's a very timely conversation that we're having today. As of this morning, our company's CEO, Giovanni Caforio, actually launched a press release talking through BMS, the company, as well as BMS Foundation, our commitment to diversity, equity, and inclusion. So as part of that press release, the company announced that we are committing $300 million over the next 5 years dedicated to diversity and inclusion efforts, specifically around 5 key areas. So the first is health disparities, and I'll talk through more of that in a moment. Workforce representation, so really looking at our internal workforce and capacity. Supplier diversity, diversity in clinical trials, and employee giving. So being able, again, to have opportunities to support our communities from the employee standpoint. So really the highlight of what I'll be talking through today is really the first key piece on health disparities. And so the foundation, our model and our response to healthcare disparities was preceded even before this announcement that came out this morning. And we, as a foundation, we are missionally and therapeutically aligned with our company's values and mission to address health disparities. In 2017, I had the opportunity to lead our foundation in an effort and special focused on cancer disparities in Asian Americans, Native Hawaiians, and Pacific Islanders. Ben already alluded to some of the key statistics about the data disaggregation when it comes to cancer in AA and HPIs. But to go further with some of that research, what we were also finding was the what we call cultural determinants of health. So these are things like Adam was talking about in terms of language access, immigration, thinking about traditional versus Western medicines, information spread, et cetera. And what was even more startling in all of that research was the lack of resources and the lack of funding and investments made to AAPI communities focused in cancer disparities. So as a response, back in 2017, our foundation issued out a special focus request for proposal looking for key organizations, institutions, hospital systems that are really focused on addressing these disparities and really looking to address and provide solutions and innovations on how to attack these barriers that we were seeing in the AAPI community. So from that RFP, we issued out 4 grants, $750,000 each over the course of 3 years. So a $3 million commitment just to get us started on really understanding again what the needs were and really be able to make a stake on the ground and to be able to say, you know, when we're looking at health disparities, we're looking at it from a race ethnicity perspective, geographic barriers, rural versus urban, and so forth. And we'll talk through more kind of, I think, what those efforts have led now that we're in the 3rd and going into the final year of those projects. But those have been instrumental for us as a foundation to really understand what the needs of our communities are, not only when it comes to overall access to health, but really how that has shored up our response to COVID and our company and our foundation's response, really being able to lean on our communities and really being able to, as Adam was saying, to have that trust already established, not saying that we're coming in new, not saying that this is a new problem or an new issue that needs to be solved, but something that we have been here for some time to actually have established relationships with the community health centers, with the physicians, with the community healthcare workers. And that's part of building that trust and being able to continue the necessary work when it comes to health disparities.
Thank you so much, Priscilla. I was going to shift gears a little bit to talk about the health impacts of COVID-19 on the AAPI community, but of course, some of you have addressed it already, but so I'll just, see if you have anything more to say about the impact of the virus on our communities. But I thought it might help to kind of go back to Ben to talk about, access to healthcare is so important right now. And some in the AAPI community are having some difficulty accessing healthcare because of things like language access, public charge. So do you want to just touch on briefly some of those barriers?
Yeah, unfortunately, this is a very serious time when it comes to access to healthcare, and it's really deeply unfortunate that we've reached this pandemic under a political environment and administration that's been doubling down on many of the policies that have been acted over the course of decades under all types of Congresses and presidents, but have led to many Asian Americans, Native Hawaiian, Pacific Islanders to be uninsured or lack regular access to healthcare. In particular, I mentioned Medicaid, which is a really important safety net, and it would be for particularly vulnerable populations, people who are frontline workers on the pandemic and maybe receiving low wages, or people in multi-generational families. Medicaid is that safety net, and unfortunately, there are structural barriers for people who are immigrants in terms of accessing Medicaid. You can only be eligible if you've had a green card for 5 years. And there are certain populations, like people who are here under the Compact Security Association, who aren't eligible for Medicaid. However, even then, there's a program called Emergency Medicaid that anyone, regardless of their status, can go to the emergency room and get care to at least stabilize them. Unfortunately, while there are the Congress in its pandemic legislation so far has chosen to provide some funding through Medicaid for the uninsured, they've actually structured it in a way that people who are eligible for emergency Medicaid, these are the people who aren't eligible because of their immigration status, aren't able to get COVID-19 testing or treatment as a result. And so that's something that's very worrying, that there are people, because of their lacks of eligibility or inability to afford care, are not able to get access to testing, or even if they are tested, access to treatment. And I think, like Adam has mentioned, we've heard some really sad stories about people who have actually passed away from COVID-19 because they did not seek out treatment before the illness took a very serious turn because of their lack of access to health insurance. And those stories are very sad to hear. We're also very concerned that people may be eligible for these programs like Medicaid or eligible to go to a doctor, go to the clinics that Adam works with, but they don't because of the administration's and the Department of Homeland Security's public charge rule. This is the new rule that what came out last year, year before, had a comment period. It is now has gone through some judicial processes, and we are currently have a injunction, so it is not currently in effect, but it was earlier this year. Regardless of what's happening in the courts, though, because of that rule, and even despite who that rule impacts, which is people who do not yet have a green card or are seeking a visa, people who have green cards or are citizens are not impacted by this public charge rule. But because people fear that they may, if they use any sort of healthcare, or they may have an impact on their immigration status and they may have something revoked, or even that they use healthcare, that one of their family members may see their immigration status impacted. And so there are many, many sad stories and actually evidence now that 1 in 7 people living in an immigrant family have said they've avoided public assistance programs because of the public charge rule. And we know that within certain types of families, like lower income families, it's much higher. It's very worrying. And then I just wanted to kind of mention in that context, 3 in 5 people who are Asian American are foreign born. Many, many more live in mixed status families, and similarly is true for Pacific Islander populations. And so we know this is something that deeply impacts the AAPI population. And then the final thing I really wanted to touch on and grow on of what Adam raised about language access. 1 in 3 Asian Americans are limited English proficient, meaning that they speak English less than very well. And we've seen a really troubling lack of quality translated documents around the public health emergency. The CDC actually has been translating some documents sporadically into languages, but last time I checked, their website is still only available in 4 languages in terms of translations. We at the Health Forum have been tracking efforts on a resource tracking sheet around other entities like health departments or states or community organizations that have translated documents, but it's still really not enough. We've also heard really worrying things around interpretation. When someone goes to a hospital or a provider that receives any sort of federal funding, they are supposed to be offered interpretation services and equal access to healthcare. Fortunately, that's really not the case. Many people don't know that they have that right, and many providers decline to spend resources to provide interpretation services or provide inadequate interpretation services. We heard a story of a mother who brought her 2 kids who she thought might have COVID-19 symptoms into a doctor. The mother did not fluently speak English, and her minor children were asked to interpret for her, which is a big no-no and inappropriate in terms of both quality and patient safety. And she did not leave, and she left that provider visit not fully understanding whether or not they may have COVID symptoms. And so these are some of the things that we are really worried about and that we're looking to Congress to potentially take action on in the next COVID-19 legislation.
Thank you, Ben. I did notice that we got a question from the audience, so I'm going to jump around a little bit. And Dr. Fujioka, I think this is one for you. I'm just going to read the question. Sorry, I don't have my glasses. Obesity was mentioned as a key factor for COVID in the Asian population. Is there also a secondary element such as diabetes or high blood pressure? The Asian diet or food intake is very different than Caucasians, and I was wondering if that is a factor which gives us different health challenges.
Okay, so I'm hoping that I got the point across. So anybody that's obese, whether you're Caucasian, whether you're Asian, once you're considered obese, your risk of having a severe COVID case goes up. So it doesn't make you more susceptible, you just are going to have a more severe case. the mechanism is that fat cells make a lot of inflammatory factors, and these inflammatory factors make the disease process worse. So as far as I know, there's nothing in the diet. As a matter of fact, the typical, almost all Asian diets are actually extremely healthy if you can go back to a truly Asian diet. Obviously, it's changed a lot once you come to the US, and there's a lot more processed foods, a lot more calories, and then a decrease in activity level. So those things all pay in. So again, I don't think it's anything dietarily. As a matter of fact, I think, again, the classic Asian diet is better to anybody that's obese. But why it hits Asians particularly hard is because Asians become obese at a lower weight. So again, if somebody's 5'4", they would be obese at a weight of 170. But if you're Asian, you're obese at a weight of 130. So again, it's how you gain your weight. And Asians as a group, we just don't gain our weight in a very good manner.
Great. Thank you, Dr. Fujioka. Okay, I'm going to turn to Adam now. You know, Adam, you touched a little bit on COVID, but you and I have talked about, you know, telehealth is becoming kind of the new way that people are getting access to healthcare because of COVID. But I know that while it's a great tool to have, there are some limitations. So would you talk about a little bit about that, Adam?
Yeah, absolutely. I think before I go into telehealth, I do want to talk about like the challenges that COVID has been having on providers in general. And it really, you know, the pandemic has absolutely strained and decimated our healthcare system, particularly for community health centers that have seen dramatic decreases in patients coming into their clinics for visits and their ability to provide care. Because of this decrease. Among APCHO members, we, you know, at the, several months at the start of COVID, we saw upwards of 70% patient declines visiting our clinics. It's recovered somewhat, but we're still seeing significant drops. And without additional support for our healthcare providers, for community health centers specifically, it really does jeopardize the ability for these providers, these trusted healthcare providers within communities that serve predominantly medically underserved communities, low-income populations, to keep their doors open. Irene, as you and I, and as you alluded to, have talked about, telehealth has absolutely been a lifeline to patients for them to seek care so that they can maintain that physical distancing that's required under the guidelines, but also for for the clinics, for our healthcare providers to ensure that they're continuing the medical care and the treatment plans that are necessary for their communities. A critical challenge, though, is one, the infrastructure that's in place in the ability of healthcare providers to stand up, for community health centers in particular to stand up telehealth services, and for them to link to their patients who may not have access to the hardware that's necessary to have those video conversations with their healthcare providers. You know, we've benefited that COVID-19 and the flexibilities that have been extended by Congress and the administration has enabled community health centers and other healthcare providers to really ramp up their telehealth services. It was a very low utilization rate among healthcare providers, but it has significantly ramped up because of the flexibilities that has been entailed. But a lack of hardware, you know, many patients, particularly if they're low income, may not have access to a cell phone. They may not have a data plan that can handle video conferencing. There are broadband challenges, particularly for rural communities that may not have, again, the bandwidth that's necessary to have those video conferences. And for the healthcare provider side, it's very expensive to stand up telehealth services and invest in the infrastructure that's needed in order to have those the communication with their patients that way. So, you know, I think providing services and providing additional support to the healthcare providers to stand up these services, many of which did not have widespread utilization or didn't have the infrastructure in place, but also ensuring that patients also have the hardware that and the bandwidth that's necessary to communicate with their doctors. So I think it's a challenge on both sides. We're seeing some progress towards better health, better telehealth legislation and authorities, particularly because COVID has necessitated it. But what has been extended so far is just temporary. It's through the emergency period, which we don't know definitively when that'll end. I think it's up to HHS to determine how long that'll be, and then there's a period of time that it'll phase out, unless there is legislation that permanently extends these telehealth services, and that's something that we want to promote. And again, I think that telehealth is an important aspect of care and linkage to care, but it's only one aspect. And reimbursement rates for healthcare providers that utilize telehealth services is not the same as having an in-person visit. As the type of interaction that you have with your healthcare provider is very different on a mobile device versus visiting in person. So ensuring that there is continued support for community health centers, hospitals, other providers, ensuring that there's the infusion of resources to ensure that they can remain that their doors can remain open is absolutely critical. Ben alluded to this, that it's been unfortunate that Congress has not been able. Congress and the administration have not been able to come together to provide additional support that's needed. The past 5 COVID-19 relief bills that passed Congress have been helpful, but it's been nowhere near enough to continue our response to this pandemic. We were hoping to see legislation pass last week that would have provided critical supports, not just direct cash, not just direct monetary assistance to providers, but really more authorities and flexibilities in it that enable them to provide the care that they need to provide to their patients. And we really need members and the administration to come together to continue COVID-19 relief that is robust, that is widespread. I think, for our patients, almost 90% fall below 200% of the poverty line. 67% rely on Medicaid. So we really need to ensure that there's robust authority to support the Medicaid program, ensure that states have the resources that they need to continue to provide their federal or their state match to Medicaid, and ensure that their governments are able to continue to contribute to the healthcare providers in their states, because it really is, there's not a one-size-fits-all solution across the states, but just ensuring that the states have the resources they need, the providers have the resources they need, and the patients have the resources they need is critical. And we need, we need additional support from our government.
Thank you so much, Adam. I just want to remind everyone, we will be turning to Q&A. So if you have any questions, please put it in the chat box. I want to turn now to Priscilla. I was just reflecting on how Carolyn Ha talked about, pharma companies are working very hard to find vaccines, treatments, and other things. What are things that organizations like yours can do to make sure that it will be accessible to all communities, but especially to the AAPI community? I don't know if you have any thoughts about that or
yeah, so again, just as a full disclaimer, I'm with the foundation side. Right. So our kind of red wall in line is with the treatments and branded products. But I think, from where we sit on the foundation is you can have all the innovations, you can have all the drug advances in the world, but if it's not getting to the communities who need them the most, then you're missing, right? You're missing the big picture on it. And so I think going back to, the work that the foundation had laid out, and especially in AAPI communities, and when COVID first struck our nation, we were able to immediately turn to those communities and be able to say, okay, tell us what your needs are in these emergent and urgent times, and to be able to appropriately and quickly respond. So by and large, many of our grantee partners listed PPEs and safety equipment and health equipment as almost the number one, and not just for their staff and clinics, but really even the patients that they were encountering and serving as well. We also had, as Adam said, with the issues with telehealth, one of the big challenges and barriers was on the provider levels and making sure they had the appropriate equipment and knowledge of engaging patients through telehealth models and so forth. So we did a lot of training and basically uptaking of the digital health and telehealth for many of our community partners and physicians to be able to help them transition during this temporary time for in-person visits to virtual and digital visits as well. And I think, that's been one of the biggest lessons and stories for MORISA as a funder and a foundation is you needed to be able to have these established relationships from the beginning and not necessarily because of COVID or because of any specific moment that now you're willing to respond, right? The community and the public is not going to look at that favorably. They're going to be asking the question of, were you here from the beginning? Are you here to stay? And I think that's been one of the biggest messages from what we've heard from our grantee partners was the continued commitment and the continued dedication, because we know this work is hard. We know that this change is hard. It's not going to change overnight. COVID, even with a vaccine or with a treatment, is not going to overnight change our nation. There's going to be a lot of other milestones that will be necessary. But I think the messaging in terms of what our company is responding as a company as well as a foundation, I think that's been critical. And, again, thinking about how COVID has impacted the AAPI communities, again, it wasn't necessarily COVID created more disparities or created new disparities. It was a magnifying glass. It highlighted and magnified the disparities that already existed in our communities and made it into this condition that we're in, where we can no longer ignore the problems that are on the surfaces and underneath the surfaces. And so now it's kind of this question and onus for us on this panel, for APACs and the congressional leaders of where are we moving? How are we going to respond to this pandemic, not only to patch up and to put Band-Aids on things that are broken, but really how are we going to change the system to be able to respond appropriately and create a new one for one going forward. And I think that's where a lot of our conversation, we know kind of now we're getting a better picture of what the problems, what the disparities are, and I think now it's kind of what are the solutions? How do we innovate together to create this new system that we need? So I'm going to pause there because I know we want to save some time for questions from the audience as well.
Yeah. Well, thank you, Priscilla, and thank you for talking about sort of the bridging the gap between public policy, public organizations, community organizations, and the private sector. So thank you. I think that the panelists have been so thorough that we don't have any more questions at this time. You were very thorough, and I think provided a lot of good information. So I think at this time, I'm just going to ask you all just for some closing thoughts. So I'll start alphabetically again with Adam to see if you had any closing thoughts before we close the panel. Adam?
Yeah, no, I think we've covered a lot in this, in this panel, and I think that what I do want to underscore is that there are very unique challenges, but also opportunities for the Asian American, Native Hawaiian, and Pacific Islander communities. One, to improve their health outcomes, but also to, as Priscilla was saying, to really transform our healthcare system to provide better care to communities that are targeted, that are specific to the patient and their cultural and linguistic backgrounds, and that can really lead to better health outcomes. And if there's one thing that I want to assure folks who are listening is that there are many advocates who are working to help improve this, but we also need support on the ground to ensuring that our voices, that their voices are heard by their policymakers. So, if you do see a challenge, whether it's healthcare specific or just in general, contact your members of Congress, make sure that our elected leaders really do know that we are listening, we are watching them, and that we expect them to work on behalf of our communities to improve our health outcomes and to improve the quality of life for our communities and the nation as a whole. So really do get involved, do be engaged, even if do be engaged, and know that you have allies and partners in that fight with you.
Okay. Actually, we do have a question, so I'm going to pause right here. I'm just reading it. I'm seeing for the first time, current literature shows that there is a very, very low participation in clinical trials for current vaccine candidates. Like many other drugs, this may mean low relevance efficacy for these potential preventive options. Are any of your organizations involved with or interested in technology enhancements that can outreach to encourage participation and push validated information to our very disparate communities? I'm an Asian American physician licensed in Maryland on the Maryland State Suicide Commission, and we need disaggregated data. Someone want to take that?
I'll take the information piece, and I think that'll lead well to Ben and Adam probably being able to speak more on what they're actually doing on the community side. So thank you for the question, and I think you're absolutely right. You know, when it comes to vaccines or clinical trials and drug treatments in general, there is definitely a low percentage of participation from the AAPI communities for a host of number of reasons, whether it's stigma, whether it's messaging, and so forth. And you're right, I think when it comes to a COVID vaccine, there's going to be similar challenges and barriers, whether it's development, research and development side or the dissemination. So I'm going to focus more on the dissemination because again, that's kind of where I sit on the foundation side. And you know, we've definitely been, as part of the work that we've been doing already with our partners, one of the things that has come up is been the basically two things. One is the in-language challenges and barriers. So being able to have the information in appropriate languages for many of our AAPI communities where English is not their first language. I've been kind of already touched on that. But the second is also the channels where patients are receiving their information from. So, you know, whether it's who's the trusted individual, so whether it's providers and making sure that they have the right information to be able to provide their patients in language, and be able to help patients advocate and be able to assert themselves with any questions that they may have, any clarifications, concerns, etc. But I think the second part in terms of channels and where patients are getting their information is also understanding where are the pieces of information that patients are getting information from in the public, right? So we know that in AAPI communities, depending again on, you know, kind of your ethnicity and where you go, you may go on Facebook, you might go on WeChat, you may go on WhatsApp, right? And how these information spreads. So I think learning kind of the social media channels and where patients are getting their information, we know that it can be so easily misinformation spread, and I think that is definitely going to be a big challenge. So being able to, again, think about putting ourselves in our patient's shoes and where they're coming from can hopefully help us kind of get ahead of that curve and ahead of that barrier when we're talking through kind of, you know, whether it's vaccines, the development of it, or the accessibility of it once it's been approved.
Adam or Ben, do you have anything else to add? Okay. Thank you, Priscilla. Oh, go ahead. Sorry, Ben.
No, I think that, you know, the creating trust and providing culturally competent language, appropriate materials is going to be really, really important for all steps. There's a lot of, you know, bad history in this country when it comes to communities of color and medical research. And there just needs to be a lot of work and resources that are required to overcome that. At the same time as making sure that when vaccines for this current virus or any future ones are available, that, you know, we know that access is a major barrier for those, as well as cost, and making sure that we don't let those sort of things be in the way of really good public health approaches such as vaccination.
Do you have any other closing statements at this time, Ben? Otherwise,
I'll just say, you know, when we talk a lot about social determinants of health, it's a big catchphrase these days, talking a lot about how most of someone's healthcare outcomes are related to not what happens in their doctor's office, but what happens with their built environment, their physical space, their housing situation, what they eat, who they live and work with. In addition to that, I think it's really important that we, as Adam was saying, make sure that policymakers know and are aware that much more structural social determinants of health, such as immigration and racism, are really barriers to achieving healthcare right now, and that we have to overcome them. I very much agree with Adam that policymakers right now need to know that people who care about the health of Asian Americans, Native Hawaiians, Pacific Islanders are watching them, and that while what has been done so far has been good, it hasn't been enough, and it's excluded and in fact perpetuated existing disparities among communities of color, and particularly among lower income communities of color. And so I think we all need to work together going forward on both some of the kind of things that we can do that are obvious, such as lifting restrictions to health insurance programs and providing more materials and language, disaggregating data at the collection, analysis, and reporting level at all levels of geography. But also, really, we know this is going to be a long-term process, and that these policies that I'm talking about are really the result of kind of the systemic societal problems that we have to root out. But I will say I am, despite feeling really sad about the great losses of life, particularly among Asian American Pacific Islanders we've seen in some communities under this pandemic, I've also seen policymakers have a much higher interest in health disparities now than before. And that's something we really need to build on together.
Thank you so much, Ben. Dr. Fujioka, thank you again for being here. Do you have any final statements you'd like to make?
Just one, and it'll cover both the question that was asked and this really is a message to pharma. I'm a researcher. I've done over 100 clinical trials. So in clinical trials, for those of you not familiar, if you want to get a drug or hormone or device approved in the US, you have to test it in literally thousands of patients across the US. And depending on your outcome, if it's improvement in blood sugar, improvement in weight, and there's no safety concerns, you get approved. And I've asked this numerous times to pharma that they put in there that they have X number of minorities in these clinical trials. In other words, if you just take patients that come in, it's unfortunately usually all Caucasians. But if you were to stipulate, okay, we want X number of African Americans, we want X number of Asians, we want X number of Hispanics before you get approval, then it would happen. And so the FDA could do it on their end, or pharma could do it on their end. And I'm not sure who's going to do it, but as Priscilla Coe mentioned very earlier, clinical trials to me is where you would make this change and get something tested in the Asian population. The only time I've ever been asked to do a study specific on Asians is when a company wants to go to, say, Japan or China, and they say, look, we need a bunch of Japanese patients because the Japanese won't take our data because there's no Japanese in the study. Well, of course, that makes sense. And so, say, a cholesterol medication, many cholesterol medications are handled differently by Asians. Our livers are different, and so we don't break them down right. So it turns out you have to change the dosing. You have to lower it, and you still get the same effect. If it's too high, you get problems. And so we found this out years ago. And so in essence, if they're going to another country, sure, they're going to want to test it for that country. But in the US, we need to start doing it because, and again, in California, our fastest growing population is the Asian population.
Thank you so much. I mean, I think we hear that a lot, but to hear it from an actual researcher, I think is very, really underscores the need for that. And I think that we all need to do more to educate our communities about the importance of participating in clinical trials, but also, there are obviously some historic issues, but also providing that education and maybe working with some of these trusted intermediaries to get more APIs into these clinical trials. So we probably could have an entire session on this. So maybe we could think about that next time. Priscilla, do you want to wrap it up for us before we close?
Yeah, I think my closing remarks is just that representation matters. I think even before or in preparation for this panel, I just had a call with one of my grantee partners, and he was saying, if you look at the National Institutes of Health budget, 0.2% of their entire budget was given any focus to Asian Americans, Native Hawaiians, Pacific Islanders. If you look at public and private foundations and you look at the data of how many dollars are given to the AAPI communities, that's 0.4%. So by and large, it's woefully underrepresented. And, you know, I think that's where a lot of kind of these concerns come from, where we're funders, or most of the majority and public, don't see an issue when it comes to health and AAPIs. And so that means that we have to be our own advocates. I don't take this position of privilege lightly, of where I sit in the foundation, and how I've been able to somehow influence a little bit of our foundation and its focus when it came to addressing cancer disparities in AAPIs. And so I think that's, you know, just a call to action for this group here. You know, there's a lot of really young, really hungry, really passionate, whether you're in research, whether you're in policy and all of that, your voice matters. Your advocacy matters for this community and for our community. And so that's what I'll leave you with, and the charge that I'll leave you with today.
Thank you so much, Priscilla, and thank you to all the panelists for spending the time. I know it takes a lot of preparation to do these panels, so I really appreciate you taking this time and educating us. I think there was a diversity of issues, but I think they all came together, and I think that one of the things that we all learned is that, you know, educating ourselves about the health issues that impact the API community, but also making sure that we inform whoever our doctors, researchers, companies, policymakers about those issues. So again, thank you for participating in the panel. Thank you to Apex for inviting me to be the moderator. And I think at this time, I'm turning the reins over back to the president and CEO of Apex, my good friend, Madeline Milka. I don't see her face.
Yes, you are. I am here. I am here. Thank you, Irene, for facilitating this important discussion. And thank you to all of our panelists for joining us for this conversation today. And a special thank you to our panel sponsors, Bristol Myers Squibb, Novo Nordisk, and Pharma. And for those of you who are interested in getting the recording of this panel, you can by visiting the Apex Facebook page, as well as our YouTube channel. So we encourage you to share the link to your networks if there are others who might have missed it in the live stream itself. And if you don't know yet, Apex Gala, AKA Asian Prom, is going virtual this year. So you can see the virtual celebration on October the 1st. And so we encourage you to register on the Apex website so that you can get access to watching this virtual event. Next week on Wednesday, August 19th at 2 p.m. Eastern, we hope you will join us for the next panel in our Legislative Leadership Series, where we will be hearing from state and local AAPI elected officials from around the country. And you can RSVP and join us by visiting the Apex website again, and enjoy the rest of your afternoon. Thanks so much.
Thank you all.